a paracetamol. And then you go to weak opioid analgesics with an adjuvant analgesic. Step 3, you go to minimum invasive interventions. Adjuvants like now you're putting in a central line or you're pushing in morphines and all that. And then strong opioid analgesics. The opioids now with a higher dose, or you can do a patch or one of those. So it's actually important to always remember that I've put in on our chart the palliative care approach. The other thing is also to offer support system to help patients live an active life as much as possible and right up to their death. You've seen us discharge patients home and discharging patients home to be able to have their last moment with their grandchildren, with their grandfathers, or wives or partners with their partners. And also to provide psychosocial and spiritual care. We live in an environment where a lot of our patients are spiritual. So you even see, even as you're giving your treatment, some of them will actually really want to have their spiritual support. We've seen the Catholics, for example, have the last rite, the last sacrament that they are able to give. So those are important. So step 1, we said aspirin and paracetamol. Step 2, we said codeine, the hydrocodeine, with or without an nonsteroidal anti-inflammatory, such as brufen or indomethacin. Step 3, morphine, with or without aquanalgesic, such as fentanyl, and other strong opioids, such as pethidine. Let me just put that on the chart. So those are critical. This is still just a bit of medical introduction around what happens, the palliative care issues. Now let us go into the ethical issues. So somebody, when Marlene was putting up her Mentimeter, she asked you, what do you think are the medical legal issues around palliative care? So I want us to rewrite them again. And if you write, you can just say one line. What are the things that she projected? Hello, good people. Hala. See, Marlene aliwapea Mentimeter. So Robin, I'm asking, what are the ethical issues? You know, when you talk about medical, legal, ethical issues that we have to think about when we talk about palliative care. I'll give you an example. Autonomy. There are 7 things you usually talk about. Dignity, confidentiality, I like. Informed consent, I like. They form part of some of these. They are the build-up to some of the issues, yes. What is autonomy? Beneficence, Helen, yes. What is autonomy? Let's start from first, do no harm, yes. In fact, in Latin, it's called prima non seresa. Let me get that very clearly. Prima, yes. Prima non nocere, do no harm. What do we understand by the word autonomy? And you can mute your microphone and speak. Kelly, I like freedom. Freedom goes together with autonomy, self-preservation. I like Marlene, the patient has the right to make their medical. In fact, the word I'm going to include in a sentence, Marlene, is the patient has the right to make an informed medical decision. And then we'll be able to actually dissect and ask, what is an informed medical decision? So I was asking, who wants to say a few words about autonomy and give us an example? Or let me rephrase. Do any of you think you have autonomy or the ability to make a decision without influence in your life? Let's start basic. In your life. Does any of you think that they have? Who is that? That's a very strong yes.
Kelly.
What decision do you think you have the right to make without influence?
medical